I'm Mike Cole. I'm an associate director in the Center for Innovation in Population Health. I live in Nashville and had spent a lot of time, 20 years of my career working at Vanderbilt with the two speakers I'm about to introduce. I think I have a minute, and so I'd say I only have a minute to introduce Kathy Gracey and Tarah Kuhn, who are two people who have had an immeasurable impact on me, both personally and professionally throughout my career. I've known Kathy since 2000, I believe, and Tarah came to work with us in 2005. So I've known them both for a really, really big chunk of my life. Kathy and Tarah are both on faculty in the Department of Psychiatry and Behavioral Sciences at Vanderbilt University. They both currently work in the Center of Excellence for Children in State Custody, a center that has, I think, just celebrated its 20th birthday. Kathy is there as the Director of Quality Programs, and Tarah is the center's clinical director. So Kathy and Tarah are going to talk to you today about Tennessee's journey with TCOM implementation, a journey that started, I think, in 2005 and continues today. And I'm sure that as they give their talk, they're going to be talking a lot about what you often hear in these kinds of talks. They'll be talking about collaboratives and all the great partners in the system, and they'll give a lot of credit to all the people who have helped Tennessee on this journey. What I know they won't say is how important each of them have been personally to the journey. Kathy and Tarah have been the consistent driving force behind what's now been 20 years of really effective reform and improvement work in the child welfare system in Tennessee. They're both passionate about the kids they help and the families we serve, but they possess, I think, uniquely that combination of talents that allows them to bring really creative solutions to really hard problems in a really tough system. And they do it kind of bridging that gap between the university and all the promise of science and in a TCOM implementation, all the great data that we can bring to bear on problems, and the community. And so with that, I think I'll be quiet now and I'll let you hear from two of my absolute favorite people on the planet. Kathy and Tarah.
Thanks, Mike.
Thank you, Mike.
I'm going to go ahead and get us set up to share. Hopefully I can do this correctly.
And I'm just going to say good morning and hello to our TCOM community live here from Music City in Nashville, Tennessee. I feel like we've been introduced, a wonderful introduction by Dr. Cole. Thank you. And Tarah, I'll let you kick us off.
Are we good? Slides are good. We're looking all right?
Looks good.
Great. So just that first disclaimer here. Oh, is it? It seems like I'm not moving forward. Hold on. There we go. Just disclosure. We don't have anything to report. No conflicts for us. Just to kind of give you a sense of, Mike mentioned, the Center of Excellence where Kathy and I have been kind of operating out for the last 20 years. The Center of Excellence is a part of a statewide network. And Kathy will talk a little bit about how this came into being because it's connected to kind of our journey into TCOM. But we exist as one of 5 centers that are part of a statewide network where really the goal is to kind of collaborate and improve services for kids at risk of custody or in custody in the juvenile justice system. And here at the Vanderbilt COE, we are a little bit unique in that we're one of 5, and generally the 5 of us kind of serve regionally across the state. The Vanderbilt COE is here centered in Nashville, and so we have kind of taken on a lot more statewide projects in our reach as a COE is a little bit broader across the state. But primarily what we do is a lot of consultation services. So our direct line of service is consultation around complex cases for child welfare, other agencies involved in child welfare. And we do a lot of dissemination and training of best practice. And part of that is that as we kind of identify needs and gaps in the system from a clinical end, we also want to be poised to be able to connect kids and families with services that meet their needs. And so we do a lot of dissemination of best practice in terms of our provider network in the state. And then what we're going to talk about today is kind of our best practice implementation and quality improvement projects, which is where a lot of our CANS and FAST and our kind of TCOM related initiatives are housed. And so that's kind of where we are operating out of, is the Center of Excellence for Children in State Custody at Vanderbilt.
Thank you, Tarah. So today what we'd really like to do is tell our Tennessee story of how our CANS and TCOM implementation came about. Our story begins with a lawsuit called the Brian A. lawsuit. Some of you might be familiar with that, or it might be a lawsuit that you're familiar with actually in your own state. What this did for us, it evoked a strong sense of urgency for a policy and a practice change. There were very specific mandates outlined in the lawsuit. One was all children in DCS custody shall receive an assessment using standardized protocols. The second mandate was all children shall be placed in accordance with their individual needs, taking into account least restrictive and the most home-like setting. And the third mandate was as soon as the child's assessment was completed, the child's placement would be reevaluated to ensure that the placement could meet the child's needs that were identified by the assessment process. So this was our beginning. Initially, the department partnered with 3 of our centers of excellence in each of our grand regions, a center in the east, a center in the middle, and a center in the west. Vanderbilt was in Middle Tennessee, and so we were the middle partners. And they wanted us to assist in the implementation of an assessment practice that could assist in meeting the requirements that were outlined in the mandate and in the lawsuit. So this is how we started our journey into TCOM. Of course, for a lot of you, you might remember back then, TCOM meant total clinical outcomes management. So there's been a change in communication and how it is we think about TCOM, even since we started our journey. So in partnership with DCS, our first TCOM implementation was the CANS, which started in 2006. As you can see, we have a lot of TCOM implementations beyond the CANS to date with all of these initiatives, which have helped our state to embed the TCOM philosophy and framework across many child-serving systems. Beyond the Department of Children's Services, we work with the Department of Mental Health and Substance Abuse Services, with our Administrative Office of the Courts, and with many juvenile courts across our state. Again, this is a snapshot of where we started and where we are, and we want to reflect on this journey with you guys today and talk about the lessons that we've learned along our way. Our journey was not a straight line as shown in the previous timeline. Our road to TCOM looked more like a winding road with a lot of twists and turns. Our initial why, again, out of the lawsuit, that DCS had no standardized way to identify what kids and families needed. Each region had some kind of homegrown version of how it is they were assessing kids. So we needed a standardized practice. And after much research, the department chose the CANS. Beyond the lawsuit mandates, the commissioner at the time, which was Viola Miller, wanted the assessment to identify what kids and families needed to reach permanency and maintain an improved sense of well-being. So DCS leadership at that time partnered with John and the 3 COEs. Initially, the focus was really on building that collaboration between the department and the COEs around this project in implementing a statewide implementation. So we needed to identify stakeholders, both at the central office, DCS, and across the state with regional leadership.
One of the things too there is, thinking about that building piece of that project. I know I got involved in 2005 and our timeline starts in 2006. And there was a lot of kind of laying the groundwork, researching and building that went into even before that first point went on the timeline. And I think that's really one of the places in implementation that I know we fall into traps around often, which is kind of wanting to do things quickly because there's a great need to fill, and sometimes in that haste, really not hiring great people and building a great team. And so thinking about kind of that timeline and that road, really thinking about how slowing down that front end and identifying that stakeholder group and that great team.
Yeah, that's a great point, Tara. So once these stakeholders were identified and a lot of time spent in preparing and thinking through a strategy of how to implement and identifying the team that could implement, we moved into hiring good people. Building a great team was a top priority. Some of you may remember, and I don't know if people from South Carolina, if you're on or not, but your current commissioner, Mike Leach, was our first CANS consultant. Of course, DCS took him away from Vanderbilt within a 2-year time frame, and he's developed into a child welfare expert that has run many departments in child welfare and now is commissioner in South Carolina. I remember this being a very, very exciting time. This was new, it was a new initiative, and we really kind of felt on fire. Our consultants spent a lot of time with John Lyons those first couple years, and boy, did we drink the CANS Kool-Aid. Thinking back, I think we were more excited and comfortable about training the CANS assessment, the manual, not so much focused on the philosophy around TCOM. Probably the first year and a half between John, who spent a lot of time in Tennessee, I think I was his driver on most of those trips. We got all staff certified to complete the assessment on paper. And that was the primary focus. And we definitely developed and honed our training competencies. Training the manual and the items became really, really easy. I remember one of the hardest parts in those trainings were getting to the practice vignettes, where we had to harness the ability to not go down those rabbit holes and try to argue what the trainee's score should be as opposed to the expert score. How many of you remember your first training? Well, if I could see the reaction buttons, I'd probably see some hands go up. Our first training covered everything you should not do. Tara was the driver. We had our team of people. We got in her van. We get in and she said, I'm probably going to need to get gas. Now, the training was an hour away. We showed up late. Thank you, Tara. We did not get through the entire manual, and it was a full day training. So we ended up ending late and also had to reschedule the entire group to come back to finish training. Definitely not a way to start. But
sorry.
Yeah, go ahead, Tara.
I was going to switch to our next slide, just thinking about how that structure of the implementation across the state is unique. And one of the things I think in that really early phase, before we even kind of rolled out, was how do you support all of these? How do you support all of these regions? It was a big task. So thinking through kind of that structure piece.
Yeah. This definitely is our structure. And I want to kind of start and reflect a quote that Simon Sinek, who I love his YouTubes, but he says, a team is not a group of people that work together. A team is a group of people that trust each other. And I think that through this hiring process and really creating this structure to support the implementation, that we really grew tight as a team, and a team that did trust each other. We initially had 3 COEs, one in the East, Middle, and West, managing the implementation. But within the first couple years, it was decided that to support more uniformity across the state, that Vanderbilt would manage the entire statewide implementation. So Tennessee is very unique. We have the Vanderbilt COE consultants in every single one of our regional offices. We have 26 master's prepared consultants along with 2 supervisors embedded in all of the 12 regions throughout our state. And they train, certify, recertify, they consult on the assessments, and they provide technical assistance within those regions. When requested, we definitely will attend child and family team meetings. We're embedded into a lot of teams within Department of Children's Services, like the well-being teams, and we work very closely with regional leadership. And we provide this statewide support to all of our TCOM suite of assessments, not just CANS, but also FAST, and more recently, the TENS, which is our infant mental health assessment.
I think this feature, Kathy, is one that is really central to kind of the success that Tennessee has had, because I feel like that while these consultants are Vanderbilt employees, they really do live in the regional spaces, and I think are very much part of those regional teams and become, you know, like even the reflection to me is like they use their Tennessee government emails more than they use their Vanderbilt emails. Like if you want to reach them, that's the way to get them. They really are part of those teams and do things that are outside of even kind of their assessment or consultant related roles, where they get involved in other projects and just are a support more generally clinically even for their team. So I think this structure has been really significant for kind of the implementation in Tennessee.
Yeah, so off we go. We've got our teams embedded across the state. We're training, we're consulting. And I will say another early memory that I have of our implementation was the development of a web application that could support the data entry around the assessment, so we could move away from pen and paper implementation. So we did this in collaboration with DCS IT. My memory is sitting in the room with a bunch of business analysts and a lot of IT people. I remember this whole process really made my head hurt. I remember coming out of those meetings, full day meetings, and my brain felt like it had gone through a workout. And I'm not a person that works out, so it you know, if I were to work out, I would have muscle soreness probably for weeks. But my brain, I would walk out of those and yes, that my brain felt sore. But the lesson learned here is that putting time into that development of the IT is well worth it, because it definitely can make or break an implementation.
And I think, Kathy, you really, I mean, I remember those days, and you really learned that language. You learned a new language, and I think that ability to kind of crosstalk that was essential, because I don't think that IT and the business analyst people could have done it without the kind of child welfare systemic lens that was needed. So I think you're kind of taking that on this.
So we got through that. And then once we moved into that web application, I will say that the way it got built, it was super user friendly, had a lot of functionality. But in 2010, we had to rebuild into the Tennessee SACWIS system. This slowed the workforce down. I would define this as definitely one of our sharp turns in our implementation road. And the implementation had to adjust. The web app had functionality like pre-populating scores. So when you did reassessments, you could see scores before. The summary page was really user-friendly. But then we went to our SACWIS system, which we call TFACS. Well, gone was the user-friendly system, and we had to adjust to a lot less functionality and not so pretty summary reports, along with the workforce having to learn a completely new system that also operated very slow. But one advantage, Vanderbilt started getting data extracts from the system, so we could start designing reports that would prove useful to the department. And we did that in collaboration with the department. So we did quarterly reports, which is basically your descriptive data, race, gender, age, along with needs, strengths, identified at a statewide level, but then you could look down to a regional level also. We created heat maps. One report was a 75-mile report where we could identify if a child was placed within 75 miles of their removal address, which was, I think, a requirement. If not through the lawsuit, it was a federal mandate. We had heat maps, compliance maps showing the percent of CANs completed within policy and protocol. We had network development reports showing the percent of youth needing very high levels of care and the location across our state where these placements were. So a lot of reports. And this is just a population snapshot. I think next, Tara. Yeah. Of what our population here in Tennessee looks like. These are our kids, the domains of risk, behavioral, emotional, and strengths, and what our top 5 domains or items within those domains look like. I'm sure this looks a lot like maybe your implementations and the data that you're pulling also. These are our caregivers and what their needs and strengths are. Top 5, again, I'm sure this looks very familiar to a lot of your implementations. And the next example is an example of one of our heat maps. Again, you can see over time, we got really, really good at training a lot of people and getting them to actually complete the assessment. We hit 95% compliance and have stayed at that level of compliance throughout our implementation. But I think along the way, we kind of missed the point. These were assessments that folks were completing as a tool and a checklist. And what we realized is they weren't really using it in their practice and with their families. So the spirit of the assessment guiding planning and case practice was not as high.
And I think that's one of the kind of, we had conceptualized this was kind of like the road of TCOM implementation for us in Tennessee. And I think early on, like Kathy's saying, is that we were very focused, even as trainers or consultants, around making sure that people understood how the items were defined and how to complete them. And Kathy's referencing the vignettes and how to score. And we were focused on those metrics around completion, and that 95% completion was something that we were really aiming for in that early implementation for us in Tennessee. And I think one of the things that we realized a couple of years into that, while we were really, really successful in terms of completion, one of the cautions there was that we got overly focused on compliance. And so we were kind of, the way we trained the tool and also the way we tracked the tool was as a tool. It wasn't so much as an assessment or intervention. And so thinking about one of those kind of spaces in implementation to kind of slow down and think about, am I on the right road, is this idea of kind of compliance versus collaboration. And so Kathy, you can talk maybe a little bit about kind of how we shifted today from more of a compliance lens to kind of more of a collaborative lens in the implementation.
Yeah, to your point, Terry, yeah, we got really focused on our consultant queues. How many assessments did we have in the queue that we needed to get an approval for? We got really focused on, were people completing it within appropriate timeframes? We got really focused on, were they making accurate ratings and through that consultation? But we really weren't engaging around the family story. Again, the talk was more about CANS as a tool and less about the spirit of TCOM. So we knew we had to make a shift. We needed to change the narrative for it to be something different than CANS. And what we know through science is that how we communicate to others can spark change. So we changed how we trained. We spent more time discussing TCOM at the front end of our trainings and making it the centerpiece of the trainings instead of focusing on item and item ratings. We focused more on the why. And I love this quote by Simon Sinek. As you can tell, I'm a fan. People don't buy what you do. They buy why you do it. So this really became central to us, really returning to our why. Some things that we changed pretty immediately is we moved away from calling it the CANS tool. We called it an assessment practice. We called it a best practice. This is an intervention that the worker engages the family in and other stakeholders as part of the case. And the assessment truly is the family story. And it represents that story throughout the life of the case.
I think another place of caution that's connected to kind of what Kathy was saying is having kind of maybe unclear vision or inconsistent messaging. I think because we were born out of a lawsuit that had really clear like edicts in terms of what needed to be captured and what we were kind of responding to be compliant around with that lawsuit. That was like the initial kind of vision, right? Was to bring in this tool that can fulfill the requirements of the lawsuit. And a lot of times systems see those as checklists, right? Like, check, I've done that. And that unclear vision it didn't kind of extend into kind of what Kathy's talking about, which was the spirit of TCOM. And so I think we had to spend some time in that shift early on to say, we fulfilled this mandate, and how do we want to redefine what the vision is? We don't want to stop with just the checklist of having completed that and brought this assessment in to answer those 3 requirements of the lawsuit. So we needed to kind of clarify what the vision was and also get more consistent around the messaging, both in our leadership, but also in the leadership in the Department of Children's Services and in our consulting team that was kind of bridging both of those worlds.
So we needed to reconnect to our why. So we went back to the well. We needed to pause. We really needed to reassess. So we re-engaged John and the team. At that point in time, they were at Chapin Hall. We did some additional training, as Tarah reflected, with our own team to re-energize us and really get back to the spirit of our why. And now, when we got back with John, we realized that TCOM had become transformational collaborative outcomes management. I also want to remind, if you're working with state government and state agencies, there's likely to be many change of guards. So one needs to be aware that when this occurs, reconnecting the new leadership to the Y and reintroducing them to the TCOM practice is important. We did that quite often. We actually invited John to Tennessee quite a bit for some of those key stakeholder meetings with our TennCare, which is our Medicaid agency, with other departments, their commissioners, their deputy commissioners, to kind of reboot and re-energize around the TCOM practices in our state. We also kind of looked at our training, and we were doing a lot of one-off training. So we started rebooting our training. We moved away from one-offs and really started taking a more learning collaborative approach. You guys might be familiar with that from the IHI Institute for Healthcare Improvement. And we had done some work with Mark Lardner to enhance the way that we train staff, focusing more on building consensus, teaming, and developing more trauma-informed plans. Mark introduced us to a couple of instruments called the CUSP and the CUSP. I think they've been renamed now, but it's an implementation survey for us to get a baseline of where our caseworker workforce and where our supervisor workforce and what their attitudes around using standardized assessment practice, what that looked like. So we started implementing learning collaboratives within each of our regions where we did these pre-surveys in the regions. Then we would train them, focusing much more on the TCOM principles and some of that curriculum that Mark had shared with us. Then we would do these learning collaboratives. And at the end of the collaborative, we would administer a post-test using the same instrument and use that data to have these regions build their TCOM sustainability plans. So, and we also had monthly TA calls within each of our regions. And this was truly about an 8 or 9 month collaborative that we're doing in every single region across our state. We also realized that once we energized our team, we needed to involve others on our journey to TCOM. We saw that there were a lot of opportunities where we could create connection to assist us in establishing and developing this shared vision of how it is we think about kids and families across our state. And one opportunity for connection was to make sure our providers knew the why around our CANS and FAST implementation. They were important because that's where our kids and families resided, was in our provider network. So we partnered with our monitoring arm called Provider Monitoring and Evaluation and worked with them to rebuild their entire monitoring guide and their monitoring process. It also included looking at the CANS and the FAST. And through this work, we were really able to pull our providers on board in understanding and talking the language and thinking about how it is we look at needs and strengths with our individual kids and families that we're serving. We also started offering quarterly trainings with providers and other community partners.
I definitely think if you think about this kind of road to TCOM for us, like you can see like those first few years, we were really just trying to get our feet under us in terms of understanding CANS and TCOM and getting our own internal language on our team correct in our leadership. And then in doing that and switching to the spirit of TCOM, I think that really kind of expanded our, we were looking down at what we needed to do. And I think once we got there, we started looking up and around us and seeing like, oh, if we really want to expand this and embed it in the system, it needs to go beyond the frontline staff. And so making that pivot and kind of like Kathy's saying, is like, what are those opportunities for collaboration where what we're doing on the front line can also help serve and answer questions for other parts of the system that we're operating in.
Yeah, so I really think that reaching out to our provider network was definitely a way to embed this implementation across the provider network. I think the next slide actually shows when they do their consultation with these providers. This one shows we use kind of a significant evidence of need to improve is a red, evidence of need to improve is yellow, and green is there no evidence of need to improve. So as the monitors went out, and we went out with them and monitored these provider agencies, we really looked at the teaming, the planning, the implementation of the treatment plans, and then tracking and adjusting throughout their stay at this particular with this particular provider. And what we did is we used the CANS, the identified ratings, actionable ratings of 2s and 3s, to see if these providers were identifying to the extent to identify these needs for the kids that they were serving. So it definitely, this is an example of a consultation report.
And I think similar to our consultants who are working in the regions with the frontline staff, we use that same model in this process. And so we kind of paired one of our Vanderbilt consultants with the Department of Children's Services team to kind of do this provider feedback. Similar platform. And then again, like we kind of continued as we kind of have these relationships across our child serving teams. We, in 2010, there was some changes that were happening in our juvenile justice system that kind of created an opportunity for integration of CANS into our JJ system. And so the juvenile court level saw kind of how this implementation with CANS was going in the Department of Children's Services, and had some funding changes, Kathy, that you can talk a little bit about that.
Yeah.
And prompted a need to also integrate screening into that juvenile court system.
Yeah, there definitely were funding changes that happened. Instead of the state paying for a psychological assessment for whomever a judge would want to order one for, they put that funding back to the individual courts and counties, which definitely was a change. So I think that was the impetus for the courts really wanting to move toward what DCS had implemented for the court system. We started out with, I guess, about 20 courts with this implementation, the pilot in 2010. And as of 2019, the legislature passed legislation that requires all courts to use a standardized assessment practice, and we've been able to expand to 60 plus courts that are utilizing our juvenile justice version of our CANS. And I think the important thing here is that at that point, you have two child serving systems that are hopefully understanding the assessment, can talk about needs and strengths and within families. So we also do the training and the technical assistance for that implementation. This implementation also indicates that the assessment that is used needs to have predictability. So an algorithm was designed with an identified set of CANS items, along with some additional questions focusing on risk factors associated with recidivism. And currently, the courts are using what we call the community risk results that identifies a low risk, a moderate risk, and a high risk. So we're working with our biostat team, along with some other experts. I think Mike Cull is on that team, and performing an analysis of this algorithm to see if it has predictive validity. More to follow.
So this was another kind of juncture where we were reminded of kind of in that road to implementation, like where we were hitting some kind of roadblocks because as Kathy said, like in having drank the Kool-Aid, like felt really strongly about how these assessments can help support kids and families and also address the needs that were being identified through the legislation that happened in juvenile justice. And if we were bringing kind of that energy to the table, a lot of times we were met with resistance on leadership from the juvenile justice side to say like, no, this population is different. This is why this is not going to work. And I think we really had to caution ourselves into staying out of kind of a convincing and trying to talk another system into change position, and trying to kind of stay in a place of curiosity. Like we were invested in wanting TCOM to expand because we could see what the positive outcome potential was for that. But we really needed to kind of temper that and stay in a place of curiosity to help us understand kind of what their desire and need was, understand really what their barriers and resistance, like where that was coming from, and help them to really think about how, help them think about for themselves how this implementation maybe can address those needs and kind of be aligned with their vision. So I think that is really kind of another space of caution for us, is trying to stay out of that kind of convincing chair and in that kind of curiosity space when trying to kind of engage other parts of the system.
Yeah, and along our journey, we rebooted our FAST implementation that has struggled for quite a while. The 4E waiver came to Tennessee. So one of the things it was looking to do was to expand work done to strengthen services for our in-home population or our non-custody population. And there were 2 interventions that were identified in that 4E waiver. As one was enhancing the implementation of the current front-end risk assessment, which was our FAST. So we revised the assessment, and the department also dedicated some additional resources for additional consultants to support that in-home work. And then the second intervention was to provide some wraparound services for kids and families receiving in-home services. So the particular level of services provided would actually be determined by the risk algorithm that was associated with our FAST. Again, as we implemented these assessments or rebooted, we were always looking at what can we take away from the worker, you know, that the FAST can reflect. So at this point in time, we actually took away the SDM that the frontline worker was having to complete, and again, replaced it with the safety and the risk output as part of our FAST implementation, which I think the workers were appreciative of.
Well, I think that's a good point, Kathy, because it kind of speaks to like not wanting to create burden that builds resistance on the part of the frontline staff, but then also creating a situation where the assessment is the thing that's reliant, that the system is reliant on, and creating outputs and identifying resources and connecting kids and families up. So it kind of created more meaning for those assessments for those teams as well.
So,
oh, go ahead, Kath.
Yeah, go ahead. You're going to do psychofarm.
Okay, I was going to say, so we had been, you know, kind of in this journey so far, really thinking about the assessments in terms of how they're impacting kids and families in a direct way, and then using some of those data and analytics to think about the aggregate impact. And in 2015, and Michael, who you heard from earlier, was really integral part in developing this project. We really kind of looked at how can some of the analytics that we got more savvy in using, how could they be kind of utilized to address other problems in the system that maybe are not directly related to the assessment on the ground. And so CANS at this point became kind of an integral part of developing a model that around intervening for risky practices for children in our state. And so that was our psychopharmacology Oversight Initiative that started in 2015. and this initiative was really born out of this recognition that psychotropic prescription rates are significantly higher for kids in custody than they are for the general population. And based on the literature coming out of some of these concerns, there was an identification of kind of what are deemed red flags that happen in prescribing practices. And so these 4 red flags of any psychotropic medication given to a kid 5 or younger, exceeding max dose for a recommended max dose, 2 or more medications in the same class, or being on 4 or more medications, became the kind of red flags. And we wanted to be able to think about how we could kind of intervene in a potential risky practices, as well as just kind of the maybe overuse of psychotropics in our child custody population. So we built this Oversight Initiative that had multiple parts, where there was kind of a consultation education part, really helping the system understand safe practices, intervention around a consultation process, as well as kind of looking at the prescribers in our state and identifying people who maybe are outliers in that. And that's where kind of the CANS became a feature of this project, because we used the CANS complexity score in the risk standardization model that was developed. And that model looks at prescribers and does a kind of risk adjustment based on the complexity of the kids to identify prescribers who are 2 or 3 standard deviations, maybe outside the norm of typical practicing. And so we've been working on this process for some time. We have gotten much stronger in kind of the consulting part of this process, and still kind of working on the intervention piece of it. But just another example of kind of where CANS became part of a different initiative in the system that maybe wasn't directly related to it. Kathy, do you want to add anything about psychopharm?
No, I think you covered it.
Okay. One of the things that did kind of highlight for us in this, another kind of roadblock in our implementation, is that, and you mentioned this a little bit before, Kathy, that in the systems that we work in, there's a lot of turnover in leadership, and we're kind of at the mercy of those changes at times. And so we can start a project with a certain leadership team within our state that are invested in this process, and then we have a turnover, and we kind of lose that momentum, and we lose that connection. And we also maybe have a different narrative that comes in with that administration. So really thinking about how to continually balance that narrative of kind of how is what we're doing consistent with the goals of the leadership that is in front of us at the time. So that can be kind of a challenge for the implementation.
Mm-hmm.
So kind of, oh, go ahead, Kathy.
Yeah, I just wanted to say definitely another connection that we made here in our state was with our DCS Training division. That psychopharm really was a collaboration with our health program area within our department. And so we reached out to our DCS Training department also. And because there's just a lot of turnover, we wanted to work with them on how to integrate the TCOM principles and the assessments throughout all of the training curriculum that the department had to offer wherever it was appropriate. So we worked with our deputy commissioner over training. Now all of our assessments are part of our pre-service. So right when a person's starting child welfare work, moving into the workforce, we do their pre-service training and certification. And then we embedded our recertification training into the training platform that the department uses. We've worked with...
I was just noticing our time, just wanted to be mindful of that. Kind of,
I guess the point is just, to look across the system and see where it is you can make connections.
I'm going to get us towards the end because I know we've kind of gone over our time. We've talked a little bit about our Safe Baby Court, and you guys can kind of take a look at that slide in the journey. But I wanted to kind of get us to our kind of just our takeaways, Kathy. Maybe that would be a good place to end. So we kind of try to distill that down into 5 takeaways, and we're going to do these 5 takeaways in 30 seconds or less. So go ahead, Kat.
First takeaway is leadership matters. Stay connected to leadership. If leadership changes, go back in and reconnect around the mission and the vision of TCOM and the assessment practice across our state. Tara, yours?
Yeah, connection counts. So really thinking about not just kind of like a top-down or mandate. That is not going to necessarily create change, that we really want to develop relationships at different parts of the system. And so we were doing that on the front line, we were doing that in leadership and across different domains of the system. So really thinking about how relationships kind of drive innovation and creativity. And that, I think that would be something that we would significantly highlight.
Stay focused on the why and really know that how it is you communicate about this is extremely important.
And then 4, just think beyond the tool. I think we got stuck in that really early on, and we needed to kind of use that to kind of create the framework and the for that shared language, but really thinking beyond that tool and what are the gaps in the system? How can TCOM be kind of a solution for those challenges? So kind of staying solution focused in our lens.
And keep a growth mindset. The work never stops, and we grow each and every day as we do this work. And our next area of growth is really around the families first. That currently we started July 1. So, and they definitely are using our FAST as a big part of our families first implementation and our consultants on the QRTP implementation here in Tennessee. So keep a growth mindset.
I know you had a video at the end, Kathy. I don't know if we have time for the video. Defer to our facilitators.
It is a good video and it is Music City, but I will also defer.
Yeah, you guys, this is Diamond, by the way. You should have time to go ahead and share that video if you'd like.
All right.
Great. So this is our team.
Oh, go ahead, Kathy.
I want to thank a lot of people. I want to thank our DCS collaborators. I definitely want to thank Mike Cole, Richard Epstein, John Ebert for helping us with our slides. He's an amazing colleague and has definitely very savvy PowerPoint skills. I want to thank Mark Lardner, April, John, who really have mentored our initiative along the way. And I definitely want to thank our Vanderbilt consultant colleagues who did this work day in and day out to make a difference for the families and the kids here in our state in Tennessee. Please sit back, relax, or you can stand up and dance if you want to.
So Kathy, this is a video of the consultants. These are the consultants that are doing the work on the front line, right?
Yeah, and in this work, always keep it happy and joyful.
All right, we went over time.
Sorry. Thanks, guys.
It's like a parallel process. We started with that new first training that you talked about, Kathy.
Yeah, we're always late and
we
going
went
over.
over time, so that's good. We rounded it out.